Hi everyone, and welcome to this webinar. So I might start. So my name is Marina. I'm the webinar coordinator for Evidence Synthesis Ireland, and we're delighted to welcome you all to our webinar series. So just by way of brief introduction, for those of you who might not know much about ESI, which includes Cochrane Ireland, it's an all-Ireland initiative funded by the Health Research Board and the Research and Development Division of the Public Health Agency in Northern Ireland. Our aim is to build evidence synthesis knowledge, awareness and capacity on the island of Ireland. We have a number of key activities for achieving that aim, and one of them is a monthly webinar on an evidence synthesis topic. We have three presenters today from the HRB Evidence Centre, who conduct evidence synthesis commissioned by the Department of Health to inform health policy. I will briefly introduce the three wonderful speakers we have today, who we are absolutely delighted to have with us. Louise Farragher is Senior Information Specialist in the Health Research Board Evidence Centre. In the Evidence Centre, she leads a team of information specialists who work with researchers to design and implement appropriate search strategies to find published and grey literature evidence for evidence reviews of complex policy questions. Joan Quigley is a research officer in the Health Research Board Evidence Centre. She also leads systematic reviews and meta-analysis, and previously she worked as a health technology assessment consultant for the UK and for global pharmaceutical companies. Dr. Camilla Coyle is a research officer in the HRB Evidence Centre and an adjunct associate professor in Trinity College Dublin's Centre for Global Health. She leads systematic reviews, and in the Centre for Global Health, she teaches qualitative research methods and supervises dissertations. Previously, she worked as a health research consultant for various UN agencies and non-governmental organizations. So in this webinar, the speakers will describe their approach to conducting mixed methods reviews using two case studies. They'll focus on how they design mixed methods search strategies, their use of machine learning via text mining for screening, and how they analyze and integrate qualitative and quantitative findings. So just in terms of housekeeping, we've turned off video to ensure there's good sound quality for all our attendees, and we will have time for questions at the end. So we do encourage you to type your questions in the Q&A box down below as the webinar is ongoing. And a recording of this presentation will be made available on the website later today. So that's it from me. I'll now hand over to the wonderful team in the HRB Evidence Centre, and thank you all so much for joining, and we hope you enjoy.
Hello everybody, and I'd like to thank Marina, Nikita and all the team at Evidence Synthesis Ireland for inviting us to be part of this ESI webinar series. It really has been a great series so far, so I hope we don't let you down. My name is Louise Farragher, and I work as an information specialist in the Health Research Board's Evidence Centre, and I'm joined by my colleagues today, Camille Coyle and Joan Quigley, both research officers in the Evidence Centre. So just briefly to go through our agenda for the day, I'll give you a little bit of background about the HRB Evidence Centre and explain about our approach to searching for mixed methods reviews. Then I'll pass you on to Camille, who will discuss a case study on a review we are conducting on housing with support for older people. And then on to my colleague Joan, who will discuss a case study of a review of regional health organisations. And finally, as Marina said, we'll take some Q&A at the very end. So the Health Research Board is an Irish state agency that funds and supports research and provides evidence to prevent illness, improve health, and to transform patient care. The Evidence Centre was formed in 2011 under the specific HRB strategic goal to generate and synthesise evidence and to promote the application of knowledge and support decision-making by policymakers and relevant practitioners. The Evidence Centre comprises three teams: the Evidence Review Team, the EMCDA European Drug Focal Point team, and our colleagues in the HRB National Drugs Library. Today, we're focusing on the work of the Evidence Review Team, a team of research officers with a range of backgrounds and a team of information specialists whose main work is to provide evidence reviews for the Irish Department of Health and support policy units in a range of policy areas. And we've also undertaken some work for the Health Services Executive. So this is a selection of the HRB Evidence Centre's publications over the last 2 years. And I think it gives you an idea of the range of topics that the team has been undertaking over this time. As you can see, The topics are quite wide-ranging, from a highly relevant topic of infectious disease legislation to reviews covering the need for dental amalgam, reviews covering vaccine injury redress, and healthy workplace tools. So quite a wide variety, serving a wide number of policy units in the department. As you know, systematic and other reviews of evidence can inform the policy-making process at different stages of that process. I'm drawing on the work of Lavis 2009 here today, paper well worth having a look at. And he had designed drawn the policy process in 3 stages, where policymakers can define a policy question, assess potential policy options, and identify policy implementation considerations. More specifically, defining the policy problem can be broken down into sub-steps, where policymakers need to identify a problem or make comparisons with a range of problems or highlight alternative framings of a policy problem. Now, generally, the department don't request reviews from us at this stage of the policy process. For the most part, our work is focused into 2 other areas. So specifically around assessing potential policy options. Now, I know it's a busy slide, but if you look at the central column there, you can see that there's a range of sub-steps to assess potential policy options, from identifying policy program options, characterizing benefits or harms of an option, or characterizing the cost effectiveness of a policy option, or key elements of complex policy options, or characterizing stakeholders' views and experiences of policy options. And as you can see, there's a range of review types that could inform any of those options. Specifically around characterizing benefits or harms of policies, you have reviews of effectiveness studies. And you'll see examples of this kind of review in both of our case studies today. In addition, we've worked on areas where we've characterized stakeholders' views about experiences of policy options. And again, you'll see an example of that in Camille's case study, where we have experiences of stakeholders around a specific policy option on housing. And finally, for identifying implementation considerations, we have an example today where we have identified potential barriers and facilitators to implementation. And these can be reviews of observational or qualitative studies. And we'll see an example of that from Joan later on in the presentation. So, mixed methods review. Now that I've situated our work, let's talk briefly about them. So a mixed method review, it includes qualitative, quantitative, and/or mixed method research designs. They've been called various names in the literature, which I found quite confusing at first. They've been called integrative reviews, mixed method research synthesis, mixed research synthesis, or mixed studies reviews. Now, for the purposes of this presentation today, we're calling them mixed method reviews, just to keep everything straightforward. There's a growing interest in synthesizing evidence derived from studies of different designs. And I think that interest is growing, obviously amongst researchers, but I think policymakers are also seeing the benefit of including research based on different designs as well. However, mixed methods reviews, because they combine quantitative and qualitative evidence, they can be a challenge because of the multiple synthesis options. And really, that's something that Camille will come back to at a later stage of the presentation. But what it refers to really is whether the synthesis takes place in sequence or if it's in convergence. But Camille will give you a little bit more detail on that in her presentation. What I would summarize by saying is that mixed methods give you the best of both worlds. You're getting the strengths and benefits of aggregative or quantitative reviews designed to join up studies and to test theory. And you're getting the benefit of configurative type reviews or more qualitative reviews, which can be more explanatory and often generate theory. But this, of course, has implications for people in my line of work, which, of course, is the searching end of the review process. Because approaches to searching for both of these kinds of reviews can be quite different. Traditionally, searching for an aggregative or quantitative review would have involved a single, very pre-planned search well in advance. And the search methods, of course, would be reported and transparent. Configurative reviews give you a little bit more flexibility, where you have a main search that is planned, but it's followed by more iterative searches, and there's an opportunity for those searches to evolve and change depending on the kinds of literature that's found. But again, all searches would be reported clearly and the methods will be transparent. But this segues nicely into my part of the presentation on searching for evidence from mixed method reviews. Now, I'm sure a lot of you will be familiar with this kind of process. It's a really nice graphic from the Cushing and Whitney Medical Library in Yale. Well worth pinning up on your wall if you're doing regular systematic review, just to remind you of the kind of steps involved. I'll just focus in here a little bit. Now, obviously, at the beginning of a systematic review, traditionally, after you've formulated your questions and built your team, item number 3 there is actually, it's really scoping searches, finding previous literature to situate your work in the canon. And it's really, really important to help you develop keywords and concepts for your search strategy. After you've finished finalizing and registering your protocol, you can begin to develop and test search strategies. Go straight into your search. The process of deduplication, which is never as simple as these lines might make it out. And then the team begins the process of screening abstracts. The information team go back to obtain full text. The review team starts screening full text again, and then back to citation chasing and reference chasing at that point. It looks like it looks very linear, not necessarily as linear in real life, as I'm sure many of us know. But let's see what it looked like in real life for our case study number 1. So this review was of housing with support for older people. And the review consisted of 2 research questions. What is the impact of housing with support for older people? And what are older people's perceptions and experiences of housing with support? So 2 distinct research questions there. So we designed a search strategy based around 3 key concepts: the concepts of older people, the concept of housing with support, and then we used a concept for capturing mixed methods research, and we used a pre-designed mixed methods filter. So the search strategy involves scoping searches to help generate the keywords and concepts that we were going to use in the database search. And then for this review, we decided we would do 1 comprehensive search for peer-reviewed articles in databases for both research questions. And we searched 4 databases. We searched Medline, CINAHL, Social Index, and Social Policy and Practice, using a combination of the keywords garnered during the scoping searches, and obviously mesh terms from, or controlled vocabulary terms then from the appropriate databases. And as I said, we adapted search filters. We had found a very good filter on mixed methods research, but it needed to be adapted slightly for the purposes of the review. And we found a very good filter capturing the concept of older people, but again, we adapted that for our purposes. In addition, we had a substantial grey literature search, and that involved searching relevant websites for additional publications and literature reviews that may not have shown up in the database search. And finally, we conducted reference and citation chasing of all the included studies and any relevant systematic reviews that came up during the screening process. Now, as many of you know, there's no standard guidance at the moment for searching for mixed methods reviews. But that doesn't mean that you're without guidance, because obviously mixed methods reviews include quantitative and qualitative components, and you have already very good guidance from the Cochrane Library, from the York CRD Centre, from the Joanna Briggs Institution, on searching for qualitative and quantitative research, and those guides can definitely be used to inform different aspects of your search strategy. And I said it's worth remembering that the synthesis method can inform your approach to searching, and this is whether the team is taking a sequential or parallel synthesis approach, but again, Camille will discuss that a little bit later in her section. But finally, the aim of all searches is to be rigorous, to be reproducible, to avoid bias, and to be transparent. So I'm showing you the Prisma flow diagram for the impact question, the quantitative question of this review. And as you can see there, we had search results of just over 18,000 records from the database search, which was really substantial, quite a lot of work to have to get through. And then an additional 1,000 records or so coming in from the supplemental searches. That was the citation chasing, the grey literature searches, and the reference chasing. So the question then for the team is, how do you screen 18,000 abstracts for inclusion, and how can we make that more of a manageable process? For this review, we used a process of text mining. Text mining is a form of machine learning, and it's one way of reducing this workload. For this review, we used a process called priority screening, which is found in EPPI Reviewer software. And what EPPI priority screening does is that it prioritizes the abstracts that reviewers will review first. And the aim of priority screening is for the machine to learn the characteristics of included and excluded studies and be able to predict whether an abstract is more likely to be relevant or irrelevant. From the diagram here, you can see that traditionally, reviewers would screen abstracts picked up in random sequence. There's no way of knowing when you pick up an abstract to review whether it'll be relevant or not, and you've no idea where the relevant papers are in your pile, whether it's 1,000 abstracts or 18,000. And from the diagram, you can see the red studies are the eligible studies scattered right through the abstracts. So with priority screening, the system learns based on the decisions of the reviewers. And over time, it prioritizes which abstracts to show to the team. And in practice, this means that the teams find the relevant abstracts far sooner than they would have if they had been looking for them randomly. So what did that look like for our review? So this is the EPPI Reviewer graph for the quantitative question of the Housing with Older People review. And as you can see from this diagram, you can see the graph increasing over time. The x-axis is the number of items screened, and the y-axis is the number of relevant items found. So initially we had 2 reviewers, and they screened until they both screened until they got to the point where we had screened over 1,000 abstracts and not found any more included studies. And you can see that point in the graph where the line tapers off and becomes flat. And from that point onwards, no included studies were found. Now I can show you that graph for the qualitative question of the review. And you can see from this graph that we got to the point of finding the majority of the relevant reviews by both reviewers much earlier in this review. It was a much faster process. And at the point where the line flattens out, one reviewer took over and screens the remaining abstracts. Again, all of these abstracts are being prioritized constantly by the software, so it's predicting what it thinks you want to see. And in essence, this makes the process far more efficient. And ultimately what it enables the researcher to do is to leave one reviewer to continue screening and other members of the team then to carry out the remaining work of data extraction, full text review, data extraction, quality assessment, and then obviously synthesis and writing up the report. So we'll have a look now at Joan's case study and the search process we employed for this review. Again, we had 2 questions. What are the documented positive or negative impacts or outcomes of adopting a regionalised healthcare system? And what are the documented barriers to and facilitators of effective regionalised healthcare systems? So very much a qual and a quant type question. Now for this review, we decided that we would conduct 2 separate searches to find the evidence rather than one single search. So we conducted a specific search for the impact question and a specific search for the barriers and facilitators question. Both questions shared two concepts, the concepts of healthcare organisations and the concept of regionalisation. Conceptualising regionalisation was quite difficult. So the language around it is quite unclear and not very fixed in the literature. So that was certainly a challenge for the team. But the scoping searches that were conducted in advance of the review really helped give us language to understand how to conceptualise those for the search strategy. And again, a similar approach to the search strategy for this review, starting out with initial scoping searches to help you generate your concepts and your keywords. And as I said, in this case, we had two separate searches for peer-reviewed articles from databases, and we searched through the Medline database, through CINAHL, through DARE, the NHS Economic Evaluation Database, and the NHS HTA database. We followed that with a grey literature search as well, and of course, reference and citation chasing of all the included studies and any relevant systematic reviews that were found. Now, looking at the Prisma diagram for this impact question, you can see we found a lot fewer results. Joan was thinking, I'm sure, thankfully, but just over 1,700 for the impact question. And ultimately, that was whittled down to 4 studies included in the meta-analysis. And if I show you then the Prisma diagram for the barriers and facilitators, the more qualitative question, we found a lot fewer results, just over 1,000 results to answer this question from the databases. What's really significant about this, particularly for qualitative reviews, is that although there were 27 studies included in the qualitative synthesis, 21 of those were found in other sources not found in the databases. So they came from the reference chasing and the grey literature searches. So specifically for qualitative searching, there definitely is a need to include other approaches. I would argue for both qual and quant anyway, but certainly for the qualitative questions, it is very worthwhile to investigate other manners of searching beyond traditional database searches. So now at this point, I'm going to hand you over to my colleague, Camille Coyle, who's going to give you additional information on the synthesis methods used for the Housing with Support review. And over to you, Camille.
Thanks, Louise. So as Louise said, she took you through our search strategy for this mixed methods review, and I'm going to take you through the rest of the methods. So just to remind you, our research questions for this review were: 1, what is the impact of housing with support for older people? So this is our quantitative component. And then 2, what are older people's perceptions and experiences of housing with support? So this is our qualitative component. And the Irish Department of Health and Department of Housing jointly commissioned this review because they're looking to expand housing options for older people in Ireland. So how did we go through all of these 18,000 records that Louise mentioned, and how did we decide what to include? I'll just briefly take you through our inclusion and exclusion criteria. So we defined older people as people aged 50 and over. Our intervention was purpose-built housing with support where older people have their own front door. So we excluded things like adaptations to the family home, housing with shared rooms, and nursing homes, because the Departments of Health and Housing were really looking to see what other options there are between older people living at home and those living in nursing homes. In terms of the study designs that we included for the quantitative component, we were only interested in studies that had at least 2 time points because we wanted to measure change over time in order to assess impact. So these could have included before and after studies, cohort studies, longitudinal studies, time series analyses, and RCTs. But given the nature of the intervention, we didn't find any RCTs, and that's not surprising. For the qualitative components of the review, we chose to, first of all, only include qualitative studies that had a defined qualitative methodology. And second of all, we chose to only include studies that use one of 5 widely recognized qualitative methodologies. And we use Creswell's seminal book, 5 Approaches to Qualitative Research. So the 5 approaches that he defines are grounded theory research, ethnographic research, phenomenological research, qualitative case studies, and then narrative analyses. So for the quantitative component, we ended up with 36 articles. And of these, there were 17 unique studies. And the vast majority of these came from the US, but some also came from the UK, and then Finland, Israel, and Canada. For the qualitative component, we had 39 articles that were included, and of these, there were 38 unique studies. As with the quant component, the majority of these came from the US, but we had a much broader spread of countries represented in this aspect of the review. And of course, we quality assessed each included article. So for the quantitative studies, we used a tool from the National Institutes of Health, NIH, in the US, and we adapted this. It's a tool for observational cohort studies. For the qualitative studies, we use Joanna Briggs Institute's critical appraisal checklist. And we didn't exclude any articles based on quality. Now, there are two main approaches to synthesizing quantitative and qualitative evidence for mixed methods reviews. The first is sequential, and I'm drawing on Hong and colleagues, their 2017 article that outlines these approaches. So in terms of sequential, you could start out with your qualitative synthesis, which would give you your qualitative results. And then after that, conduct your quantitative synthesis, giving you your quantitative results, and then write these up in the discussion. And of course, you could do the inverse. You could start with your quantitative synthesis, then conduct your qualitative synthesis, and then write up your discussion. The other approach would be what's called convergent synthesis. So you could either do a database convergent synthesis, and in database convergent synthesis, you have your quantitative data from your quantitative studies, your qualitative data from your qual studies, and you use the same synthesis approach to integrate these. So you might do a narrative synthesis, for instance, integrating your quantitative studies and your qualitative studies. Or you can do what's called convergent parallel synthesis, in which case you synthesize or analyze your quantitative studies using an approach that's appropriate to quantitative studies. So for instance, meta-analysis, or if that's not feasible, then narrative analysis. And separately, so entirely separately, you take your qualitative studies and you synthesize them using an approach that's appropriate for qualitative studies. Then once you have these two separate syntheses, you integrate them in a final synthesis and then write that up. And this is the approach that we chose for the Housing with Support review. We chose it because Hong and colleagues point out that convergent parallel synthesis is particularly appropriate for mixed methods reviews where you have two separate research questions, which we did for this review. So that meant that we analyzed our quantitative and qualitative studies separately and then integrated them. And we also like this approach because it really preserves the integrity of the findings from the qual and quant studies and allowed us to do justice to the two overarching research paradigms. So for the quantitative synthesis, we first conducted a feasibility assessment to determine whether a meta-analysis was possible. And for this, we considered population, comparator, intervention, measurement scale, and length of time to follow-up. And based on our feasibility assessment, we determined that the level of heterogeneity was way too high, so we couldn't conduct a meta-analysis. So instead, we did a narrative synthesis. And for this, we used summary statistics where they were available. And we also described the influence of covariates where such analysis was completed. For the qualitative synthesis, we did a thematic synthesis. This has 3 stages. First, we did line-by-line coding of text, and we used Deduce software, which is a great online software tool for this. Then we developed descriptive themes based on this coding. And then we took these descriptive themes and went back to our research question, which was what are older people's perceptions and experiences of housing with support? And we really tried to get to the crux of our research question to generate analytical themes. And the generation of analytical themes represents the stage where we're generating novel interpretations of findings. And then for the quantitative studies, we use the grade certainty of evidence tool. So first of all, we assigned a level of evidence of 3 out of 5 for our quantitative studies. And this is because all of the included studies were cohort studies. So a lot of them had high loss to follow up, and they had very small sample sizes as well. And for the grade tool, there are 4 levels of certainty. There's very low, low, moderate, or high. And we chose the second of the 4 levels. So we have low confidence in the evidence regarding impact. So really what this means is there's not sufficient high quality evidence to make definitive conclusions. So it doesn't mean that housing with support doesn't impact older people's quality of life in a positive direction, it just means that we don't know yet. For the qualitative findings, we use the CERQual level of confidence tool. So we assessed each major qualitative finding according to CERQual's 4 criteria. And the 4 criteria are 1, methodological limitations, 2, coherence, 3, adequacy of data, and 4, relevance. And again, there are 4 levels of confidence for the CERQual tool. We assigned our evidence level 3 of 4. So that means we have moderate confidence that our findings are a reasonable representation of the phenomena of interest of housing with support for older people. Now, I'm not going to go into detail regarding our individual quantitative and qualitative findings from our separate syntheses, since we're really focusing on methods today. But I am going to take you through our synthesis of our quantitative and qualitative findings. So we created a conceptual model to visually represent our synthesis of the quant and qual components. And our model is aspirational. That's because, as I said, there was insufficient high quality evidence to make definitive conclusions. So we couldn't really create a logic model. But we still wanted to provide policymakers with a really usable visual representation of our synthesis. So this is the model that we created. So on the left, we have our 5 key overarching inputs for housing with support. So these are build accessible homes and communities, integrate health and social care services. So that's the support aspect of housing with support. Enable staff to provide well-being and care. So allow staff to support older people and undergo these health and social care service activities. Publicize housing with support so that older people and their families are aware of it as an option. And learn from experience. So conduct monitoring and evaluation on an ongoing basis as it's implemented. Then we have activities under each input that we identified. And on the right, we have interim desired outcomes. And these are desired outcomes because, as I said, it's an aspirational model. And then our overall desired outcome of improved quality of life for older people. So we color-coded, as you can see, we color-coded the activities and interim desired outcomes. So the blue represents activities and outcomes that aim to improve older people's physical well-being. And the pink represents activities and outcomes that aim to improve older people's mental health and social well-being. And then the purple is about monitoring and evaluation activities leading to evidence-based practice. So these activities really represent what older people said they valued in housing with support based on our qualitative findings, but also what our quantitative findings suggest may potentially improve quality of life for older people. And interestingly, all of these activities on the left here in the top 4 inputs, all of these came from both the qual and quant findings. So each of these was identified in both the quant synthesis and the qual synthesis. In terms of monitoring and evaluation, the first 2 came from the quant synthesis, so use existing health records for quantitative evaluation, use surveys, and then the third, learn from lived experience, came from the qual. That's not surprising, that was separated out there. So you can see, because all of these came from both quant and qual, there was a lot of alignment in our findings. So by triangulating the quant and qual findings, we saw that there was a lot of overlap. For the interim desired outcomes, the top 2 came from quant, which is not surprising. The outcome of reducing time spent in hospital, reducing institutionalization, we would expect that that would only be evident in quant. But these 3 related to social well-being and mental health for older people. So autonomy and independence, social engagement, sense of community and belonging, those were identified in, each of those was identified in both the quant and qual findings. So that's interesting that there's a lot of alignment there as well. So as you can see, in terms of our color coding, there's a lot more pink than blue, right? And what that means is there's a lot in the evidence about activities and outcomes related to mental health and social well-being for older people. And that was really a key finding of our review, that although the activities in housing with support for older people related to improving older people's physical well-being is really important, activities related to their mental health and social well-being are really pivotal as well, and really pivotal to their well-being. That's what the evidence suggests initially. Again, we can't make definitive conclusions, but that's what the evidence suggests may be going on. So I think our model demonstrates the real value of mixed methods reviews. Now, as Louise said, they give us the best of both worlds. So they allow us to integrate and triangulate quantitative and qualitative findings. And this produces really usable results for policymakers. And then creating models like this also produce something that's very, very usable and a visual representation of our findings for policymakers. So I'm going to hand you over to Joan now, who's going to take you through the second case study on regional health organizations.
Thanks, Camille. So the background to this case study, it comes from the Sláintecare report. So the Sláintecare report is a 10-year government plan for the reform of the Irish healthcare system. Uniquely, it has cross-party support. So it was developed by the Committee on the Future of Healthcare. And that committee suggested that the Health Service Executive in the future will act as a more strategic national centre, carrying out national level functions, supported by regional care delivery through regional bodies, recognising the value of geographical alignment for population-based resource allocation and governance to enable integrated care. So this statement indicates that there would have to be a major restructure of the Irish healthcare system. So with that in mind, we received 2 research questions from the Department of Health. So the first question asked, what are the documented positive or negative impacts or outcomes of adopting a regionalised healthcare system? And the second question asked, what are the documented barriers to and facilitators of effective regionalised healthcare systems? And as Louise alluded to earlier, we had 2 separate systematic reviews here as we felt that the questions were going to be answered by very different kinds of evidence. So we followed standard systematic review methods for this. So we did extensive scoping here. It was really important to understand the concepts and the terminology used, particularly around regionalisation. Louise then developed searches from this. We carried out our screening and 2 independent reviewers screened the records. Quality appraisal was also carried out by 2 independent reviewers. The data was extracted by 1 reviewer and it was checked for accuracy by a second reviewer. And then data analysis and synthesis was carried out for each of the questions separately. And then we carried out a combined synthesis. So this was the eligibility criteria we used for the review. So we were interested in general population. We weren't interested in disease-specific networks. The health service had to be established on a regional or geographic basis. And the organisations had to be responsible for care across acute, primary and the social or community setting, so to be similar to Ireland. We required studies with studies for the impact review to have a comparator. And for the outcomes, for our impact review, we had 9 outcome categories that covered things like cost, efficiency and equity. And then for the barriers and facilitators, we wanted to capture key barriers and facilitators. We limited our review to OECD countries only. So for review methods, the quantitative and qualitative findings were analysed separately, as I've said. For the quantitative, so for the impact review, we carried out narrative synthesis and a small meta-analysis of impact. So we were only able to analyse, use a meta-analysis for 1 of our 9 outcome categories. For the qualitative review, we carried out a thematic synthesis of barriers and facilitators. Results from the quantitative and qualitative synthesis were then integrated. So I'm just going to give a very top level overview of what we find for the impact review. So we identified 30 quantitative studies. They were mostly a before and after design. So they would have 1 time point before the reform happened and 1 or more time points after the reform was implemented. So we quality appraised using the Effective Public Health Practice Project's quality appraisal tool. So with this, 3 studies were found to be strong with respect to design and/or analysis. 13 were found to be moderate and 14 were found to be weak. So similarly, looking at the top level results for the barriers and facilitators review, we had 27 studies included in the systematic review. They ranged in design from qualitative to quantitative to mixed methods. The qualitative data were assessed using tools that had been adapted by us from McMaster University and the Joanna Briggs Institute. With this, 2 studies were found to be of high quality, 17 were moderate quality, and 2 were found to be weak. For the quantitative data answering this question, we use the same appraisal tool, and all 13 studies that contain quantitative data were found to be weak quality with respect to design and/or analysis. So I'm going to move on to how we integrated the results from the impact review and the barriers and facilitators review. So I'm going to start with a brief introduction or recap to what is a logic model. So a logic model is a graphic representation of the theory of change. It illustrates the links among program resources, activities, outputs, audiences, and the short, intermediate, and long-term outcomes related to a specific problem or situation. And our specific situation was regionalization in a healthcare system. So logic models have long been used by planners, funders, managers, and evaluators of programs and interventions to plan, communicate, implement, and evaluate them. And they're particularly often used in the charity sector. So for example, Concern would use them a lot. In the last 10 years, there's been much more of a call for logic models in systematic review. So I'm going to touch on a few of the key references here. So in Anderson and colleagues' seminal paper, they called for logic models to be used to support systematic review processes, indicating that they can increase transparency and understanding, and particularly for complex interventions. There's also been a call for their use in health technology assessments, such as a 2016 publication. And most recently, the updated version of the Cochrane Handbook has references to logic models. So specifically with the Cochrane Handbook in mind, it outlines that there are two main instances for using logic models in systematic review. In the first instance, you could use it to help define your research question and the scope of the review. The second part it would be useful for is when you're illustrating the results of a review by graphically summarising how the interactions between the intervention, the participant and context may produce outcomes. So this last point is what we utilised especially in this case study. A key reference for us when conducting this review was this Cochrane Systematic Review by Glenton and colleagues. So it combined the results of a typical Cochrane review of effectiveness and a qualitative synthesis in a logic model in a parallel synthesis design. So this was our process. So this is a photo of us when we were working in the office together back when that was permitted. So we did several steps to get to a logic model. We took inputs and outcomes from both the review of the impact review and the barriers and facilitators review and put them on cards. Each barrier and facilitator got its own card. And then we spent a very long time organising these cards iteratively to make the most sense logically for what we had learned from the literature. We drew the logic model then using Google Drawing software. We refined the logic model by presenting it to the wider review team. So we presented it and got some feedback and incorporated that into our logic model. So this is a shell for our logic model. So at the start, we had inputs. So we define this as direct inputs from the Ministry of Health or Department of Health to the regional health organisation on an ongoing, once-off or regular basis. This leads on to short-term outcomes. And these are outcomes that are achieved in the short term, and they are decided on by the regional health organisation for the regional health organisation. The intermediate outcomes are managed by the RHOs, and they're expected to be achieved once the short-term outcomes are in place. The long-term outcomes, these are long-term health system outcomes that were the results of the RHOs working together to achieve healthcare goals. So the inputs in the short-term outcomes mostly came from the review of barriers and facilitators. And the intermediate outcomes and long-term outcomes mainly came from the review of impact, although there was some overlap. This all accumulated together in this logic model presented on this slide. So obviously there's a lot going on here because we're trying to cover a whole health system. So to give an example of what's going on here, we'll focus on one of the chains of action. So we'll start with provision of funding. So our input here is provision of funding. So this is provided by the Ministry of Health or the Department of Health. This leads on to a short-term outcome, which is where the regional health organisation is trying to set a realistic budget. An important facilitator coming in here is that the Department of Health must use a resource allocation formula that captures local needs. So once the short-term outcomes are achieved, we can lead on to the intermediate outcomes, where we have appropriate resource allocation and good operational functioning, again within the regional health organisation. This leads on to our long-term outcome. So it's a long-term goal of the regional health organisation to have a balanced budget. But again, an important facilitator coming in here is that the Ministry of Health or the Department of Health provides support and advice. So it's particularly important for regional health organisations that are early in their development. So early on, this is very important. And overall, that this will lead to an efficient health system as a long-term outcome or goal. So now I'm going to talk a little bit about the impact from this particular systematic review. As Camille's review is still ongoing, whereas ours was published last year. So we featured in the Sláintecare Action Plan. So this is the 2019 deliverable. And as you can see here, the draft HRB report was received by the department last March. And what you can see it in action is here. So some of you may recognize the map on the right, and these are the new geographical boundaries for the regional health organisations planned for in Ireland. So our review was one source used to inform the geographical boundaries drawn by the Department of Health. So we provided information on things like that if the population of a region is too small, it would be at a disadvantage. And this is because, for example, they might not be able to bulk buy in the same way a larger region could. Also, if there are too many regions, so too many regional health organisations, it's a barrier to strategic change. It's hard to manage those organisations and it's hard for them to work collaboratively. We have outlined important barriers and facilitators, as well as outcomes to monitor, which will be used by the Department of Health as they continue to implement this reform. So I'm now going to finish up with some take-home messages from our presentation today. So mixed methods reviews draw on the strengths of both quantitative and qualitative evidence. They are useful for the triangulation of findings, so we're getting evidence from two different types of data. Models can form a key output of mixed methods reviews and provide policymakers with a valuable visual representation of results. Mixed methods are especially useful for policy questions because they can capture the impact as well as perceptions and experiences of implementation. And just to finish with a quote from Tricia Greenhalgh on this, she said that the pragmatic gold standard for a policy useful systematic review might thus be a timely, mixed method, broad scope review that embraces multiple disciplinary perspectives and gives a comprehensive, though not exhaustive, summary of the state of knowledge, ignorance and uncertainty in a field. So thank you. That's the end of our presentation.
Joan, Louise and Camilla, thank you all so much for that really insightful presentation, really informative and a lot of practical tips there. So thank you so much, and it's so great to see that